Thank you for joining us. I'm Dr. Noelle Jacobson, and I'm serving as the moderator for this event. I'm a certified nurse midwife, women's health nurse practitioner, fellow of the American College of Nurse Midwives, and course faculty here at Frontier Nursing University. Welcome to Caring for Pregnant People After Roe, Nursing Ethics and Patient Privacy in the Dobbs Era. Since the overturn of Roe v. Wade, clinicians with varying personal convictions about abortion will be challenged to provide ethical nursing care when patients present with complications of pregnancy, miscarriage, or abortion. This continuing education session is designed to help nurses understand their ethical and legal obligations, considering patient privacy, different state contexts, and their personal convictions. We're recording this on August 22nd, 2023. Please note that the legal landscape is in flux, so things may have changed. However, the ethical principles discussed remain the same. I'm honored to introduce you to our presenters. Dr. Laura Mans-James is a certified nurse midwife, women's health nurse practitioner, certified nurse educator, a fellow of the American College of Nurse Midwives, and an associate professor at Frontier Nursing University. Dr. Mans-James' clinical experience as a midwife and practice director centered on underserved population in rural areas. Dr. Mans-James has published with a multidisciplinary Black-led research team engaged in participatory action research focused on improving pregnancy outcomes for urban Black mothers and babies. She has additionally published papers on research methods relevant to health equity. Most recently, she has written about nursing ethics in the post-Dobbs era. Dr. Monica McLemore is a tenured professor in the Child, Family, and Population Health Department, and she will become the Associate Dean for Equity, Diversity, and Inclusion in the University of Washington School of Nursing, pending approval from the Regents. She retired from clinical work in 2019, though she continues to provide flu and COVID-19 vaccines. Her research is focused on reproductive justice. Dr. McLemore's peer-reviewed articles, op-eds, and commentaries have been cited in 5 amicus briefs to the Supreme Court of the United States and 3 National Academies of Science, Engineering, and Medicine reports. She became editor-in-chief of Health Equity in 2022. Lauren Pock, JD, is Senior Research Counsel at If, When, How, where she focuses on in-depth legal research in support of If, When, How's litigation and policy team and state and grassroots advocates. Lauren has authored and co-authored legal scholarship on constitutional standards for reproductive rights, international human rights law as it relates to assisted reproductive technology, and state harms at the intersection of immigration and abortion for young people in Texas. She will now discuss the work of If, When, How.
So just to give a brief introduction to If, When, How, I want to explain 3 things. First, we are national and we're very nerdy. We work on law, policy, direct support, litigation, and building out our movement. Second, we are advocates and attorneys who believe strongly in working toward reproductive justice by attempting to transform the legal system while collaborating across movements and acknowledging the intersection of identities and letting that shape our work. If this is your first introduction to the term reproductive justice, don't worry, we'll disambiguate that later. And then I also wanted to share that we are working to build a world where all people have the power to determine if, when, and how to define, create, and sustain families with dignity, and to actualize sexual and reproductive well-being on their own terms. In short, we want our work to be in service of the creation of a new world because the world we live in right now does not allow for equitable access to all of the things that I just mentioned. However, the specific piece of our work that I will be focusing on today is self-managed abortion, or abortion that happens outside of the clinic or hospital that is self-directed by the pregnant person. And with that, I will turn it over to Dr. Mans-James.
All right, we want to start with a disclosure to learners, specifically that FNU, Frontier Nursing University, is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers, a commission on accreditation. And in order to obtain the contact hours for this activity, learners must complete the entire video activity and complete a post-evaluation with a score of at least 70%. Please do note the expiration date and credit hours associated with this activity, and I want you to know that we presenters have no relevant financial relationships or conflicts of interest to disclose. And with that out of the way, let's talk about our objectives. By the end of this session, we hope that participants will be able to identify at least 3 routes that patients may use to obtain medications for safe early abortion in the United States, describe their legal obligations to preserve patient privacy in the context of medication abortion and miscarriage management, recall their ethical responsibilities to provide patient care in emergency and non-emergency contexts for pregnant, miscarrying, or post-abortion patients presenting with complications, and finally, recognize their legal and ethical rights to exercise conscience clauses regarding the care of patients presenting with pregnancy or abortion complications. And I'm just going to put a pin in the idea of what conscience means, because conscience we often think of as being associated with objection. Sometimes conscience is also associated with provision, and Dr. McLemore will be talking more about that in a little bit. So a little roadmap for what to expect. We're going to just start with some introductions and some definitions and talk to you a little bit about who's having abortions in the United States and why. We're going to talk about self-managed abortion and how the landscape has changed since the Dobbs ruling. And we'll also talk about consequences of care denial, criminalization of pregnant people around abortion, HIPAA requirements, and conscience clauses and the ANA Code of Ethics. So I want to start off by just saying that we know that people have strong convictions about abortion, and they're very varied. People have a lot of different values around this, and this presentation is really for everyone. This presentation is for you if you believe that abortion is a human right, and it's also for you if you believe that abortion is morally wrong. If you believe that abortion is okay for other people, but not for you, and certainly if you have ambivalence about abortion. You are welcome here as a clinician who takes care of others. We also realize that abortion can be a bit of a tender topic, and so will some of the other things that we're going to be discussing today. So we want to give you a little bit of just some examples of what we're going to be discussing so that you can protect your own spirit. So we're going to be discussing methods of early abortion, what happens when medically safe abortion is denied, and we're going to discuss some real-world consequences of racism on health, safety, freedom, and families. We'll also be discussing nursing roles and ethics related to abortion. We want you to get some support if you need it. If these topics do bring up difficult feelings, we want you to know that FNU has free counseling available to students, faculty, and staff, which is accessible through the portal page, and our DEI office is here for you as well. So we'll start with some key definitions and concepts. We're going to talk about early pregnancy loss, which you may think of as miscarriage, and that is the loss of an intrauterine pregnancy within the first trimester. We'll also talk about abortion, which is an intervention to end a pregnancy, typically in early stages. Autonomy is the right of individuals to self-determine and make decisions. It's a key principle of medical and nursing ethics. And finally, we're going to talk about safety today. And I think as clinicians, we've often been taught to think about safety as being about medical safety, about risks that we define. But for our purposes, we really want to clarify that safety is what the patient says it is, not just what we as clinicians might believe. And we're following sort of the idea that Linden and all, the conceptualization of safety that they have recently published about, that it's not just the absence of physical harm, but it's also the absence of emotional harm. So there are a lot of nursing roles that happen with abortion care. So nurses diagnose pregnancy through pregnancy testing, and that may lead to discussions about options. And advanced practice nurses may perform early procedural abortions in 16 states and provide medication abortion currently in 19 states. And RNs may staff abortion clinics and telehealth services, but also nurses are on duty when someone with an abortion-related concern or complication presents for care. And not all of these nurses are comfortable with abortion, and we acknowledge that. So settings where these issues may come up include emergency departments, triage lines, urgent care centers, ORs, PACUs, ambulatory care clinics, Really anywhere where someone can get a positive pregnancy test is a setting where these issues may come up, or where they may present to care with a complication related to an abortion. So it's not just happening in abortion clinics. So who has abortions in the US, and how does that happen, and when and why? So the first thing we want to say about that is that abortion is universal and it's common, and abortions happen in every country, whether it's legal or not. It's also an ancient practice. It did not suddenly spring into being in 1973 with the Roe decision. The earliest recorded reference to abortion is about 3,500 years old and happens on a piece of Egyptian papyrus. And there are references to abortion in Greek and Roman medical writings of the time. The World Health Organization estimates that 3 out of 10 pregnancies worldwide end in abortion, and unfortunately, 45% of those are medically unsafe. In the United States, approximately 24% of US women will have had an abortion by the age of 45. And we're going to use the word women in this presentation, but we want to acknowledge that not everyone who needs an abortion is a woman. And we should also say that our accuracy of data around abortion really depends on its legal status and reporting obligations and stigma, because when a practice is stigmatized, it tends to be underreported. So most abortions in the United States take place early in pregnancy. Almost 80% occur by 9 weeks, and nearly 93% happen by 13 weeks. And abortions are most often sought by people who already have children, so 60% have already given birth. It's also accessed more by poor and low income patients, 75%. And that makes sense when you think about the fact that one of the 3 most common reasons reported for abortion is being unable to afford to have a child. So 3/4 of patients are poor or low income who are seeking abortion. It's also sought more often by Black, Indigenous, Latina, and other people of color. And that's because we have a history of medical racism and reproductive coercion in this country that impacts trust in clinicians and also in contraception. There has been a very long and documented history of state-sponsored reproductive coercion in this country, and that is not unknown to patients. And it does affect how much trust people have in the medical system. It's also because access to high-quality contraception care is shaped by structural racism, and that's included with a number of different aspects, including access to insurance, which in this country is very much linked to employment status, and Medicaid expansion is different state by state. So sometimes higher efficacy methods may be out of reach for some of our clients. So abortion safety depends on policy, and it also depends on privacy. I want to just stop here and note that abortion is considerably safer than continuing a pregnancy to term. You'll see different figures on this, somewhere between 12 and 14 times safer, but just to kind of put some real numbers around that. In 2018, which is the most recent figures I could find, 2 people in the United States died related to illegal abortion. In that same year, 656 people died of other pregnancy-related causes. The average for legal abortion mortality in this country is 1 person per year. Now contrast that with medically unsafe abortion, which does result in morbidity and death. And again, to kind of put some numbers around that, before Roe versus Wade passed in this country, in 1965, 17% of all maternal deaths in the United States were due to unsafe abortion. We know that abortions that occur later in pregnancy are less medically and socially safe than early abortions because there's more chance that others will know. And that leads to the possibility of increased chances of things like intimate partner violence and also a potential legal involvement, as you'll be hearing about later. Later procedures are also more expensive and less accessible, and they tend to involve more complications. Policies that reduce access to safe abortion cause delays in care as appointments become scarce, and that increases gestational duration. Abortion in the United States is changing, and most abortions in the US until mifepristone, one of the medications used in abortion, was approved in 2000, most of these were procedural, using aspiration. First trimester abortions using suction procedures are very similar to endometrial biopsy. So many nurse midwives, WHNPs, FNPs can easily perform these procedures. It's well within their scope of practice technically. But as we'll see in a little bit, it depends on the state where those things are legally available for APRNs to provide. And procedural abortion is not possible to safely self-administer. That probably sounds obvious, but it's important to say as we think about the differences between procedures and medications. So the onset of the pandemic and some other political and access trends changed the most common method of abortion from procedural to medication abortion. And as of about 2020, medications surpassed procedures as the primary abortion method. And it's now estimated to be around 53% of abortions that occur in the US are medication abortions. So what is medication abortion? Typically, two drugs are used, mifepristone and misoprostol. Misoprostol alone also does work for early abortions, but with lower efficacy and more side effects. The FDA has approved this combination of two medications for up to 11 weeks after the last menstrual period, and the World Health Organization has approved the same combination for up to 12 weeks. It is medically safe to take all doses at home, so it's private and controllable by the pregnant person. And again, provision by advanced practice nurses is regulated state by state, despite clear and lengthy evidence of safety. Medication abortion is very effective. If these medications are administered between 6 and 8 weeks after the last menstrual period, it's 96 to 98% effective at completely resolving the pregnancy. And between 9 and 12 weeks, it's 95% at effective at complete pregnancy resolution. Now, these rare adverse events do happen more commonly after 9 weeks, and more doses of misoprostol may be needed to resolve the pregnancy. The primary adverse effect we might see would be heavy bleeding, but most people with complications from medication abortion do not need to be hospitalized. So how is medication abortion accessed in the United States? Probably most commonly, it's prescribed by a clinician and is accessed either in person or via telehealth. However, there are 3 other ways that folks in the US can access medication abortion, and our statistics are less solid around these other ways because there's no requirement that these are recorded. And in fact, clinicians aren't really involved in this at all. So one way of these sort of methods that don't involve obtaining medication from a clinician is to obtain it from a pharmacy in jurisdictions where direct provision from a pharmacist is legal. For example, someone traveling to Mexico City, where that is a possibility. Some people obtain their pills by internet, and then the pills are mailed to the patient, and PlanCpills.org and AidAccess.org are 2 organizations that are available to fill these orders. Keep in mind that in order to access medications this way, the patient has to have a credit card and access to the internet. So it's not available to everyone. Plus, they have to know that it exists as an option. Pills are sometimes also obtained by personal contacts. So someone else obtains the medications and then provides them to the pregnant person. And again, we're really not sure how often these last 3 routes are happening because there isn't great data to track this provision this way. And I will now turn it over to Lauren Pock to talk about self-managed abortion.
Before we do a quick transition, colleagues, I really want to jump in and just provide a resource to our listeners and to the individuals who are really wanting to make the connection between abortion access and the Black maternal health crisis, and to really concretize for them that there are really, really great tools and resources available to talk about this in a destigmatizing way. The Black Women's Policy Roundtable came together, and I'll make sure that this URL is available to people watching this webinar. They came together to create some important talking points around the relationship between decreased abortion access and maternal morbidity and mortality. And I think it's really, really important to just highlight one very particular and important distinction that needs to be made about the relationship between those two things. And that is, in the states where abortion access is already limited, where it is already illegal, and where it already was restricted, are the same states where pregnancy-related outcomes are also poorer, and we see a greater representation of maternal both morbidity, meaning complications from pregnancy, as well as mortality, and that those two things are related at a policy level and not just a clinical level. So I really appreciate that overview, and I really appreciate the opportunity to really, really think broadly around the relationship also between clinic administered abortion as well as self-managed abortion, in addition to procedural abortion versus medication abortion.
Thank you for that.
Thank you so much. Can we go to the next slide, please?
Mm-hmm.
So self-managed abortion is as old as pregnancy itself. And with new medical technologies, safe abortion outside the clinic is becoming more widespread and accessible. Self-managed abortion is not a back alley abortion or a DIY abortion. It is an abortion that happens most commonly in someone's home, done in privacy and safety, often with the help of a friend, family member, or a caregiver. And as an important note, we don't want to encourage any unsafe methods of ending pregnancies, but we do want to ensure that no person is stigmatized, arrested, prosecuted, or punished for ending a pregnancy, regardless of the method that they use. And so I'll go ahead and read this out just in case someone can't see the slide. So self-managed abortion is an abortion that someone does on their own. It takes place outside contact with traditional medical systems. It is often supported by friends, family members, or partners. It can be with the same medication regimen used in a clinic. It can be through traditional cultural means, and at times it can be through unsafe means. And I'll just repeat, no one should be criminalized for their abortion, regardless of the method. Next slide, please. So I think that whenever folks hear the word self-managed abortion, sometimes they might be thinking about what was going on pre-Roe more commonly, which is this image or this specter of a co-hanger. So a self-managed abortion prior to widespread legalization of abortion was often with procedures or instrumentation of the uterus. But a major medical breakthrough occurred after Roe, the evolution of modern medication abortion. Though methods of self-managed abortion vary, as knowledge of medication abortion rises, self-sourced, self-managed medication abortion is becoming one of the most common methods folks use today. In the 1980s, misoprostol developed for treatment of gastric ulcers. However, it was quickly found to have the side effect of inducing miscarriage. Its origins in abortion are actually from being used to self-manage. It came to Brazil in 1986, and Brazilian women quickly started using it for abortion. Brazilian women are credited with finding the safe and effective regimen of misoprostol-only abortion. Meanwhile, testing on mifepristone started in 1982. It was first licensed for use in medication abortion in 1988 in Europe and was licensed in the US in 2000. Early Miffy regimens used other prostaglandins. However, in 1993, the first large-scale study of the mifepristone and misoprostol combo took place. Next slide, please. So what data has found is that self-managed abortion is both safe and effective. This is data from a study from Aid Access, which is an online self-managed abortion service. A patient fills out a form online and a doctor reviews it and dispenses medication. The doctor is typically within the United States unless someone is in a restrictive state, in which case the doctor is typically outside the country. But either way, there's no ultrasound, there's no virtual or phone visit, there's no direct communication with a clinician. The success rate of medication abortion through Aid Access has been similar to traditional medication abortion given by mostly doctors, sometimes APRNs, at over 96%. Only 1% had any serious adverse event, though these were more concentrated in patients who were greater than 10 weeks gestation and usually consisted of blood transfusions. We know that misoprostol is much more readily available than mifepristone. Fortunately, self-managed abortion with misoprostol only is still safe and effective. The SAFE study, and that's SAFE, all in capital letters, looked at self-managed abortion with community support in Nigeria and Argentina for over 1,000 women. These patients obtained pills from a pharmacy and used them at home without clinical support, though they had accompaniment support from trained non-clinical abortion counselors. The study looked at patients up to 22 weeks using Miffy and Miso and Miso alone. The Miffy Miso patients used Miffy followed by 800 micrograms of Miso 24 to 48 hours later, with an additional 400 micrograms of Miso if no expulsion in 3 hours. The misoprostol only patients used 800 micrograms of Miso for 3 doses. And so you can see in the chart that for patients less than 12 weeks, the percentage of patients who had a complete abortion without intervention at 4-week follow-up. For patients who took Miffy and Miso, 95.7% of patients had a complete abortion compared to 99% of Miso-only patients. This study also found self-managed abortion to be non-inferior to in-clinic abortion up to 9 weeks, and rates of complications were also very low. And it's incredibly important to recognize that while the FDA-approved regimen for medication abortion in the United States includes both mifepristone and misoprostol, and that's what we're used to, we have no need to be concerned about the efficacy and safety of misoprostol alone. Next slide, please. So the World Health Organization actually supports self-managed abortion. It has such a proven track record that the World Health Organization's latest abortion care guideline, which was published in March, now strongly recommends self-management approaches. And the guideline recommends the same regimen used in the SAFE study that I described just now. And now I'll pass it back to Dr. Mans-James.
Okay, so as we've just heard, evidence really does support self-managed abortion. And part of that is because we know from data that people can accurately date their own pregnancies using their last menstrual period. They can determine whether or not an abortion is complete, and they can decide when they need medical backup. And this data comes in part from settings where health education and literacy may be low. And we have 15 years of data to support that pills that arrive through the mail are safe to use. And just another point, because I know many of us are concerned with ABO incompatibility, RhoGAM isn't needed before 12 weeks completed gestation in order to prevent isoimmunization. So I want to talk a little bit about mifepristone access, because I know it may be a thing that is kind of just people wonder about. And I'll say that we are recording this today on August 22nd, and changes may happen in this access between then and when you are watching this later and what has happened today. So just a very brief history. In the year 2000, mifepristone was approved by the FDA with special restrictions for prescribing called REMS, Risk Evaluation and Mitigation Strategy. So with this particular form of approval, specially certified physicians were the only people who were able to initially prescribe mifepristone, and the delivery, the distribution had to be in person for this. Now in 2016, the FDA revisited mifepristone and said that advanced practice nurses could also become certified under REMS and prescribe independently. In 2021, during the pandemic, the FDA determined that REMS could safely be modified to be less restrictive, allowing more telehealth and distance provision. And in January of this year, the FDA permanently removed any in-person requirement for mifepristone administration, and they also expanded access to mifepristone by adding certification for pharmacies in order to improve access. So right after that, in April, we had the first ruling in a case from Texas that was really designed to reverse FDA approval of mifepristone. We also recently, as of I believe last week, had a ruling from the Fifth Circuit that upheld some of the original findings in this first ruling. But at this point, access to mifepristone is occurring based on the January 2023 regulations until the Supreme Court can review it. If the limits are upheld, advanced practice nurses may have significant practice limitations imposed, and telehealth and mail provision may be eliminated for mifepristone. So that's a wait and see at this point. So medications for early pregnancy loss or miscarriage are actually the same medications. And I think it's important to say that because the legal status of mifepristone actually impacts miscarriage care as well. We know that adding mifepristone to misoprostol actually encourages faster resolution of the pregnancy, and it's now the recommended regimen for medical management of miscarriage to help resolve the pregnancy sooner rather than a wait and see approach, which is another option for people. Either one are considered reasonable standards of care. But just to highlight how the regulation of these medications affect more than abortion. So what has changed in abortion provision and miscarriage since the Dobbs ruling last July? We're just going to go over that briefly, and I'm sure my colleagues will jump in as needed. I think it's important to say that most laws around abortion provision are really aimed at clinicians and distributors rather than at pregnant people themselves. And I know that we'll hear more about that in a little while, but I just want to kind of highlight that before we talk about some of these changes in access. And another thing to say about access is that for many United States citizens, particularly BIPOC folks, abortions were really out of reach functionally long before Dobbs happened, because of where services were available and how difficult it was to access them due to travel requirements based on where clinics were located. So this landscape is not new for many, many Americans. However, since Dobbs, we know that travel times to reach clinic care have increased, sometimes 10 times or more, depending on where a person is located. We also know that as fewer clinics are open in fewer states, clinic care is just harder to access because there are just fewer appointments overall. And partially because of this reduction in access, there has been an increased interest in medication abortion. And also as people learn that, this is an option that is safe, that is controllable entirely by the pregnant person, that is private and can happen in their own home, that doesn't require travel, that's also a reason why people are more interested in medication abortion.
Dr. Mans, James, let me jump in just to also add that the social supports and the abortion funds were also impacted greatly in terms of access. So for this audience, there was a group under the National Network of Abortion Funds, which still is a regional / state-by-state group of entities that would provide people with financial, transportation, social support if they needed to travel for abortion, and even if they didn't. And so the abortion funds, because for many people, there are a variety of reasons why they can or cannot use insurance, can or will not use either their employer-sponsored insurance in states where abortion is not covered by federal funds. The abortion funds were also impacted in their capacity to support individuals with social supports, including transportation and food and gas and other things for people to access abortion. Even medication abortion itself has also been limited as well. And I feel it's important to also highlight that as an issue.
Thank you, appreciate that. So as the availability of clinic care has been reduced for all of these reasons, including the ones that Dr. McLemore just mentioned, there's been an increased interest in and use of pills that have been mailed from overseas. So we mentioned Aid Access earlier, and I just want to explain that it is an organization that was founded in 2018 by a Dutch physician, and it uses international pharmacies that are not subject to US laws to mail mifepristone and misoprostol directly to patients in states where they're not able to get it legally according to the provision laws of that state. So this is just a headline from July 7th of this year saying that they were seeing an increase of requests based on this ruling that came out of Texas that I just mentioned a little bit ago that imperiled access to mifepristone. So I think it's also really important to talk about what has happened since the Dobbs ruling that has impacted people's healthcare and that has impacted the way that clinicians have felt able or less able to actually provide the standard of care based on some very unclear legal terms and laws passed in their own states. So Grossman and colleagues authored this article, Care Post Roe, documenting cases of poor quality care since the Dobbs decision. And they took 50 narrative reports from clinicians between September of last year and March of this year from 14 states with abortion bans. And they compiled those in this article. And the most common scenario reported by clinicians was preterm premature rupture of membranes. And the standard of care previously with this scenario where fetal survival wasn't possible was that a termination of the pregnancy was undertaken or at least offered at that point. Instead, with these new very restrictive state laws, patients have been sent home to await labor or signs of infection or sepsis instead of getting a termination to their pregnancy. And this has resulted in several severe infections that have included ICU stays, including one that ended in a disseminated intravascular coagulation, which is a very, very serious condition. One clinician's quote was, the patient asks me, could she or I go to jail for this, or did this condition count as life-threatening yet? The patient was worried in the throes of sepsis whether or not she was ill enough to have this clinician end her pregnancy so that she could survive, and was worried about the risk, the legal risk to her and to the clinician under these really, really difficult conditions. In other cases, PP-ROM resulted in required travel to another state for care and resulted in delays as long as several weeks for several patients. Other poor quality care that Grossman and colleagues documented were delays in ectopic pregnancy care, including required travel to another state. And as those of us who do maternity care know that, an ectopic pregnancy can become life-threatening without much warning. Very, very quickly, a tube can rupture. So sending someone to another state really did put people's lives in danger. Other patients with underlying medical conditions, for example, postpartum cardiomyopathy, for whom a pregnancy would be cardiovascularly dangerous, were unable to end pregnancies in their home states. There have been several documented cases where the pregnancy included lethal anomalies to the fetus who had unfortunately had conditions that were incompatible with life. And in those conditions, in some of these states, their clinicians still felt unable to intervene in these cases because there was still a fetal heartbeat. So instead, these pregnant people and their partners and their families needed to travel to other states to get abortion care, or they had to continue their pregnancy until they gave birth. And there's some very compelling testimony out of the Texas case that I urge people to listen to about what the impact was on these families for having to continue a pregnancy that they knew was not going to result in a live birth. Miscarriage management, as we mentioned, has been jeopardized by limits to medication abortion provision. And in some cases, pharmacies have refused to fill prescriptions in some of these states. So even though there was definitely not a viable pregnancy, they were still unable to get medications that would help them resolve the pregnancy in the ways that they chose. In one case, there was a denial of a liver transplant after a donor had been found because pre-op testing, the patient was literally going into the operating room to receive a liver transplant, showed a positive urine pregnancy test. Now, this patient had an IUD in place and did not want to continue to be pregnant. And this was a very early pregnancy, probably around 5 weeks, given that the HCG quantitative was in the thousands, but the transplant was still canceled. So that person did not get a liver, even though everything else was set up for that to happen. So these cases are they are not many in number, but it is chilling to imagine the threats to life and to health that many patients in states where abortion has been severely restricted or banned that they are experiencing as a result of these limitations. So, what happens when safe abortion is denied beyond those major medical complications I just mentioned? What else happens? Well, the good news is that we have a study that helps us to know what happens. This was a large study of 1,000 pregnant people who were recruited between 2008 and 2010, and the study was conducted by an experienced team of research scientists at UCSF. And this study, called the Turnaway Study, was a prospective study with longitudinal data collection using mixed methods. And participants were followed for 5 years after an abortion was sought, and either was provided or was denied based on the gestational limits in their area. So some of these patients, about half, went on to have abortions, and half continued their pregnancy because gestational limits required them to remain pregnant. And these participants were all interviewed or surveyed or both every 6 months for 5 years. And more than 50 publications have resulted from this study. It's a very famous study, and 2 books have been written, and there is a theatrical play that has been written about the Turnaway study. So what did it find? What are the consequences of abortion denial? So people who wanted abortions but were turned away, in comparison to those who had desired abortions, they were 4 times more likely to live below the poverty line 5 years later. They were more likely to experience serious pregnancy complications, including death and eclampsia. So 2 of the people who were in the group who was turned away in the Turnaway study, 2 of those pregnant people died of pregnancy-related causes, even though they had requested an abortion, wanted an abortion, and were denied that care. And they ended up dying of a pregnancy-related cause. People who were denied abortions were more likely to remain with abusive partners. They were more likely to experience mental health issues and a loss of self-esteem in the short term, defined as the year after the abortion was denied, though not in the long term. They were less likely to report that they had aspirational life plans in terms of employment or education for the coming year. And they were more likely to have poor health status for years after the pregnancy, including chronic pain conditions. I'll also note that some work has been done from a demographic perspective to just try to estimate what the impact of denying abortion nationally might be if it were banned completely throughout the United States. So Amanda Stevenson published this article in 2021 called "The Pregnancy-Related Mortality Impact of a Total Abortion Ban in the United States, a research note on increased deaths due to remaining pregnant." And I'm just going to read some quotes here from this article. "Non-Hispanic Black people would experience the greatest increase in deaths. Estimated pregnancy-related deaths would increase for all races and ethnicities examined. Overall, denying all wanted induced abortions in the United States would increase pregnancy-related mortality substantially, even if the rate of unsafe abortion did not increase. In terms of the lifetime risk of dying from pregnancy-related causes, denying all wanted induced abortions would be associated with an increase in risk from 1 in 3,300 to 1 in 2,800 among all women. Among non-Hispanic Black women, the risk would rise from 1 in 1,300 to 1 in 1,000. So I think we can see here that the consequences of making abortion criminalized throughout the country is not going to be equitable. It is going to fall on the people whose perinatal equity is already deeply under threat. And, for the population we are failing currently the most. And so the consequences of making a desired abortion out of reach for more people nationally would be catastrophic. And I will just stop here for a moment to see if any of my colleagues want to add anything to that before I turn it over to Lauren Pock to talk about criminalization of patients.
So I'm here today to speak to you all about the criminalization of self-managed abortion and what that means for healthcare providers and for your patients. I want to make it clear to folks that nothing I say today is legal advice or is intended as legal advice, but I hope that it's very helpful legal information. I also want to begin by defining reproductive justice, since I mentioned it earlier. So reproductive justice is a framework created officially by Black women in 1994, but utilized extensively in our history by many communities, in particular Indigenous communities, women of color-led communities, and trans communities. I'd refer folks to Sister Song, which is an organization, so Sister Song Women of Color Reproductive Justice Collective, to learn more about this framework, and I'll read their definition now. Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. So what really differentiates the framework of reproductive justice from reproductive rights is that reproductive rights has historically focused on the legal aspects of reproduction and has focused extremely narrowly on just a few things like the legal right to contraception and the legal right to abortion. Though having a legal right to something is important, as has been evidenced by the aftermath of the Dobbs decision, a right does not equal access. And reproductive justice recognizes that rights are only accessible if people have the resources they need and the support they need to access them, and that true reproductive justice simply cannot exist in the context of current systems of oppression. Reproductive justice is also different from reproductive health, which focuses and centers on the actual healthcare provision related to reproduction, but which can bring in aspects of the reproductive justice framework in order to improve the quality of and access to care. That being said, and knowing this is the framework that If When How aspires to use, I want to discuss criminalization, and I welcome my colleagues to further define reproductive justice or to talk about how they use it in their work. Next slide, please. Criminalization as a concept refers to the act of treating an action as a crime, even when it isn't explicitly a crime under the law. The criminalization of self-managed abortion, like all forms of criminalization in the United States, affects some people more than others because of their identities, their circumstances, and their geography. The way we understand this reality is to recognize that abortion criminalization is discriminatory, it's discretionary, and it's circumstantial. And how could it not be when it's occurring in the context of a legal system that is fraught with bias and overt as well as covert racism, classism, homophobia, transphobia, ableism, and many other forms of discrimination based in systems of oppression. In particular, criminalization has the greatest impact on groups of people who are already subject to increased state surveillance, over-policing, and over-incarceration, in particular Black and Brown people. For example, a low-income person of color who self-manages an abortion later in pregnancy and then seeks medical care may be more likely to be reported to law enforcement, not just because someone in the hospital thinks it's illegal to end their own pregnancy, even if it's not. The person who self-managed may also happen to fall into a category of patients who regularly experience bias and distrust from the healthcare system. They may be the same person whose community is more heavily policed and over-incarcerated. Next slide, please. So we also know that abortion is heavily stigmatized healthcare, and this may be even more true for self-managed abortion. We know that stigmatized activities already have this aura of potential danger and criminality, which makes it more likely that someone coming into contact with a patient who has self-managed or who is planning to self-manage may incorrectly believe self-managed abortion is always a crime. Next slide, please. So I want to be clear that self-managed abortion, though criminalized, is only explicitly a crime in the law for the abortion seeker in 2 states, South Carolina and Nevada. Most state abortion bans have explicit exemptions for actions taken by the pregnant person. That does not mean, however, that providers may not be at legal risk for facilitating a self-managed abortion, which I'll address momentarily. Next slide, please. So as you can see by this map illustrating criminal investigations or arrest for alleged self-managed abortion between 2000 and 2020, the politics of a state government have little to do with whether or not local police, prosecutors, and other actors might decide to investigate someone for a self-managed abortion. Whether they were convicted or not, several people criminalized for self-managed abortion lost custody of their children. At least one person has been turned over to deportation authorities, and still others were shamed and ostracized from their communities, including being forced to move due to threats or change their names because they were unable to get or keep jobs due to the stigma created. And I want to point out too that this map, in case folks are unable to see the slide, there's red mostly in the Southeast, lots of the East Coast, some of the Midwest, some of the West Coast. And I wanted to point out that there's red in states like New York and California. So it just really reveals that the politics of a state's government are not protective when it comes to whether or not people might be arrested for self-managing an abortion, because the state government can't always control every movement that a local prosecutor or a local police officer or a local healthcare provider might make in order to contribute to the criminalization of a patient. Next slide, please. So in order to criminalize individuals who self-manage their own abortions, prosecutors have utilized a real grab bag of different state laws, the majority of which were never intended to apply to actions taken during one's own pregnancy, including laws that are addressing fetal harm. So when you think about third-party harm, so for example, if a pregnant person is in a car accident, and allowing that pregnant person to be able to recover damages, both for the loss of her pregnancy and for any injuries to herself. And then drug laws and pre-Roe abortion statutes. Really, we've actually seen everything you could think of applied in an attempt to criminalize individuals for actions taken during their own pregnancy. Next slide, please. So one important way we can stop this criminalization is by helping healthcare providers, and this means hopefully us helping you and also you helping your colleagues now and in the future to understand a provider's role in halting criminalization before it starts. Healthcare providers are key leaders in opposing the criminalization of people who self-manage abortion. Official policy statements like the ones put forth by Physicians for Reproductive Health, the American College of Obstetricians and Gynecologists, and the American Medical Association have been crucial in convincing judges, especially in higher court cases, that it is wrong to use the criminal legal system to address healthcare needs. These statements also influenced the American Bar Association, which is the legal professional association, to adopt a similar resolution. I'm grateful to medical providers for many things, but I'm particularly grateful that you got a bunch of super opinionated attorneys to agree on something and then issue a statement about it. Well done. Unfortunately, healthcare providers have at times aided in criminalization, which deeply harmed the patients who sought medical care when they needed it. As just a few examples, Purvi Patel was turned over to law enforcement when she sought medical care after an alleged self-managed abortion, and the doctor who treated her called the police. Kenlicia Jones in Georgia was unlawfully arrested and charged with homicide when she sought medical care after an alleged self-managed abortion, and a hospital social worker called the police. We also recently heard of a case in Tennessee where a nurse threatened to report a patient to child welfare for getting an abortion in another state where it was legal. This same violation of privacy and confidentiality has occurred in other such prosecutions as well. And we recognize that sometimes providers are uncertain about whether they're required by law to report self-managed abortion to the authorities. My goal today is to ensure that providers know that generally the law does not require reporting self-managed abortion to the authorities, and doing so absent a law saying you can is very likely a violation of HIPAA, which I'll expand on later. And before we go to the next slide and I talk about mandatory reporting, I just want to open it up to see if my colleagues have a comment on some of the things that we've talked about thus far.
Thank you, Lauren. I do want to make a point, especially for bedside nurses or people who are not advanced practice clinicians. It is very, very important that we understand that, you know, when pregnancy's in, I want to remind you, there is no clinical distinction between miscarriage, medication abortion. There is no clinical way to know what has occurred. And I'm going to speak to this in my section specifically around the American Nurses Association Code of Ethics. But here is another really great place for people to understand what your state board of medicine and your state board of nursing can provide for you as protections. So to reiterate, there is no mandated reason to engage criminal justice system specific to any suspicions that you may have had around pregnancies ending, whether it's a miscarriage, a self-managed abortion, or an abortion that has been sought in a different state.
Hugely important. So we'll move on to discussing mandatory reporting in the next slide. And I'm sure this is something that you all are familiar with, so forgive me for going over something that you might be aware of, but I wanted to just lay the groundwork that in most, if not all states, healthcare providers are by law mandatory reporters. As you likely know, mandatory reporting refers to a state law or a state policy that requires individuals to report things like abuse, certain injuries, and other incidents, even when the subject of the report would prefer not to involve the police. I also know that some institutions like hospitals have their own in-house requirements around reporting that might be different from state-based requirements. This can quite understandably lead to confusion on the part of healthcare providers as to whether a report is mandatory under state law, or allowed by state law, or encouraged per hospital policy. As advocates, we know that the system and practice of mandatory reporting can be incredibly complicated, problematic, and fraught. In general, it can take away agency from the person or family who's the subject of the report and can make a bad situation worse by traumatizing individuals and families. For more information on how reporting can be harmful in this way, I'd highly encourage folks to check out the website mandatoryreportingisnotneutral.com, and we'll make sure to include that in the follow-up resources that you all have access to. So one of the reasons for this is that data shows us that both class and race bias exist in mandated reporting, in particular as it concerns child abuse. Though child abuse and self-managed abortion are not related, I use child abuse as an example here in part because we have the best data on it, and in part because it's one of the most likely mandatory reporting situations that a healthcare provider might find themselves in. So what data tells us is that Black and Native American families are disproportionately reported for child abuse and neglect, even though the rates of child abuse are similar across racial lines. Black children are twice as likely to be reported as white children and are much more likely to be removed from their homes. Native American children are reported at 3 times the rate of white children, and new data has said up to 4 times the rate of white children, and are also more likely to be removed from their homes. Additionally, we know that suspected child abuse is ultimately subjective, meaning that it depends on the person. And I use little scare quotes around the word suspected because that word is often in the statutes, in the laws that the states make around child abuse and when you might need to report it, as if it's suspected. So that's a problem because I might see a child's bruise and suspect or assume that they got it playing. Another person might see the same bruise and suspect or assume abuse. Similar differences could exist observing a change in a child's behavior or their appearance, or hearing about what's going on for them at home. Our suspicions are based in biases that we already hold. So that makes mandatory reporting statutes inherently very tricky to navigate, both for us and for the authorities in charge of enforcing them. And I'm sharing all of this to encourage folks to think about how bias plays a role in mandatory reporting practices and how it might play a role in how providers make decisions about reporting abortions and miscarriages to the police as well. I also want to say that if you do find yourself in the situation of being forced to make a report, either by your superior or by the law, making sure to tell the patient and their family is a way to help alleviate the potential harm of that report. Involving the family directly gives them a chance to prepare for state intervention in a way that may help families stay together or may help someone avoid excessive harm. Next slide, please. So I just want to do some main points summarizing here. In general, we are not aware of a law in any state that requires a mandatory reporter, including a healthcare reporter or healthcare provider, to report a person who may have self-managed an abortion to law enforcement. In fact, a medical provider who reports a patient to law enforcement because they self-managed an abortion or because they suspect that they self-managed an abortion may be violating HIPAA, as well as potentially state-based medical privacy laws, because some states do have medical privacy laws that are a little bit stronger than HIPAA. It's also vital to understand that providers do have some discretion and power when it comes to reporting. In particular, what providers say to patients about reporting obligations can be protective for them. Patients really deserve the opportunity to consent to a report, and letting them know that if they say certain things that you're going to be obligated to report is one way to help that consent happen. It's not perfect. I know it's passive consent, but it is better than nothing. We also know that doing that can mean that patients don't tell you everything, and that can feel incredibly frustrating as people in a helping profession who really just want to provide the very best care that you can. However, I do think that as advocates, we have to trust that people know their own lives and they can make their own decisions about when and how they might want to involve law enforcement in something. And in general, the last thing that I want to say on reporting is to frame it for you this way. The providers that I have spoken with have shared with me that the questions healthcare providers ask and the information that they're seeking in a patient encounter should mainly be guided by one thing. Is it clinically significant to the care you're providing the patient in that moment? And if it's helpful, I do want to point out the intention behind a potentially reportable incident is generally not clinically significant to care. And reporting a patient doesn't necessarily mean that patient is going to get the resources that they need. As a former mandatory reporter myself, I really think we've been sold a bill of goods that making a report is a way for the patient or client to get plugged into the resources that they need. Unfortunately, the data that I've read since then are clear that this isn't always or even often the case. So that's why we're really hoping to share some resources with you today that can help you keep that in your back pocket and hopefully alleviate the need for a report, or at least ensure a patient can be connected to resources, even if you do have to make one. So I want to shift gears just slightly and talk a little bit about information versus advice. So the First Amendment protects our right, all of our rights, regardless of our profession, to discuss self-managed abortion, to share information about it, and to advocate for ending prosecutions for self-managed abortion. So that means we can all share information about abortion pills. We can all share information about how they work to end a pregnancy. We can all share information about where and how abortion pills have been used around the world and why and how people are using them in the United States. We can also safely and legally talk about the other ways that people end pregnancies and what we know about the safety and efficacy of those other means. So there's no legal risk, not even a gray area, about sharing information about self-managed abortion. There are, however, laws in every state that limit our ability to give legal advice or medical advice to someone if we're not licensed in those professions. So for example, what I could do is tell a friend that I understand that self-managed abortion is not a crime in Georgia, and that even though someone was arrested there for allegedly taking abortion pills, the criminal charges were later dropped. That's information. What I couldn't do, and what I wouldn't do because it's bad advice, is tell that same friend that they should go ahead and order pills online because there isn't any legal risk to them. So that crosses the line into me giving legal advice. And instead, what I would do in that situation is to tell them to call the If When How helpline. So telling someone what legal or medical course of action that they should take based on their particular circumstances is not only creates legal risk for the person giving the advice, it also creates risk for the person receiving that advice. So generally, talking about self-managed abortion is fine and good and safe, and I would argue it's necessary harm reduction work. The same is true of procedural and medication abortion. Patients still need options counseling when they're uncertain about a pregnancy, and it's your right and your duty, really, to ensure that they get that care. But going beyond just giving information and giving advice is something that people without licenses to do that should steer clear of. In some cases, even people with licenses should steer clear of that, which is where you all come in. So no one can stop a licensed medical provider from giving medical advice. But what I want to raise a flag on is giving medical advice about where someone can get medication for a self-managed abortion, or in general, referring directly for a self-managed abortion, particularly in a state that bans abortion. Providers do incur some legal risk in that scenario, and I'd highly encourage folks who want to know more about that to speak directly to an attorney at the Abortion Defense Network about your specific risk assessment. The Abortion Defense Network is a really important new resource. It's a consortium of organizations, of which If When How is a part, that provides free, confidential legal advice to healthcare providers who have questions about abortion care provision or abortion care support. And also, in some cases, providers who are in a state where they're not certain if something qualifies as an emergency, and they have called the Abortion Defense Network in order to get some advice about that particular circumstance. And that's something that I think we can all talk about as this goes on, is that providers are sometimes getting really, really conservative legal advice from their hospitals. Their hospital general counsel might come to them and say, oh, you can't talk about abortion, you can't provide abortion, you can't do this, you can't do that. And unfortunately, sometimes those general counsels are just being extra conservative, right? They're trying to protect the hospital, and that's their job. Their job is to protect the hospital and not necessarily your patients and not necessarily you. So take that with a grain of salt. When you hear your hospital general counsel give you some advice that sounds like it might be on the conservative side of things, I would really recommend getting a second opinion and potentially taking that second opinion to your hospital's general counsel to talk to them about it. Because sometimes folks are making these decisions about what kind of advice they give based on fear and based on an incorrect understanding of what the law actually is. So I just really encourage you all to know about the Abortion Defense Network, to utilize them if you need them, and to just know that we've got your back. We're really trying to make it easier for healthcare providers to provide care as to the extent that they can within the bounds of the law, and to know what the risks are if they do decide to provide care that's outside the bounds of the law. I want to briefly speak about other types of referrals as well. So when a healthcare provider can't provide care themselves for a needed or wanted procedure, it's common practice, and I think that the folks here with me would argue that it's an ethical and professional obligation to ensure that the patient gets a referral to those services elsewhere. There has been a lot of fear about providing referrals for abortion given its murky legal status, so I'm going to share with you what I know about the law and what is still uncertain, with a reminder that none of this is legal advice, and that's a great place. The Abortion Defense Network is a great place to get that if you need it. So a lot of what people are worried about when it comes to referrals is being accused of aiding and abetting. This is on purpose because anti-abortion advocates have passed laws that attempt to criminalize aiding and abetting abortion access. These laws are still being litigated in order to determine which actions they actually cover. And Texas, Oklahoma, and Idaho are the 3 states that have passed the strictest laws on this topic. However, you don't need to be a criminal defense attorney to understand that if someone is going to be accused of aiding and abetting, their actions have to actually attach to a criminal act. So if you're referring someone for a legal abortion in another state, the crime there doesn't exist. If you're referring someone for an abortion that isn't legal or has uncertain legal status, that's when potential risk arises. And a referral doesn't mean you need to make the appointment directly for the patient, but it does mean you can help direct the patient to abortion clinics in a neighboring state using abortionfinder.org or ineedana.com. Telling a patient about resources to access a legal abortion is unlikely to incur legal risk. And that also includes connecting a patient to what's called a practical support organization, which can help resource travel, hotel rooms, and money for childcare or gas for the patient in order to facilitate accessing an abortion in another state. And we'll make sure that you have a list of those organizations as well after you watch this. You can also refer patients to organizations that help pay for abortion care, like the National Network of Abortion Funds. And finally, if a patient is considering self-managing an abortion, we hope you refer them to the If When How helpline so they can fully understand their legal risks. So I just want to address this briefly. So HIPAA is the Health Insurance Portability and Accountability Act, which is a federal law that's designed to address the sharing of health information. It provides some privacy protections for patients in that HIPAA covered entities, as you all are likely well aware or maybe even a part of, have specific restrictions on with whom and why they are allowed to share protected health information. There are financial penalties for HIPAA violations, and as I mentioned before, sharing a patient's private health information or protected health information, such as their self-managed abortion, with law enforcement, when there isn't a specific state law requiring you to do that, is a violation of HIPAA and could incur a penalty. And HIPAA has been a really hot topic lately, in part because of two things. So first, there have been reports that the protected health information of patients related to abortion has been released or threatened to be released to law enforcement or child protective services, in some cases in direct violation of the current HIPAA rule, and in other cases in potential violation. This is obviously of grave concern to patients and supportive providers and can lead to major harm, including patients fearing to seek follow-up care or potentially getting in trouble with the law. A recent federal proposed rule attempts to further clarify that reporting patients in this way would be a HIPAA violation, but we don't expect a final rule on that anytime soon. And in the meantime, it's important for providers to be really clear on what reporting requirements look like and to educate colleagues about not reporting patients for accessing abortion. The second hot button health privacy issue is related to interoperability requirements and how they impact the sharing of medical information across state lines. Interoperability is a really long word that just basically means it's easier for healthcare systems to share information with each other and for providers to share information with each other. And it's now the default setting for electronic health records, meaning that companies who run electronic health record systems have created them to facilitate health data exchange. Generally, this type of data exchange is important for both patients and providers and is intended to improve access to high-quality healthcare. However, a unique risk exists regarding certain types of sensitive healthcare, including abortion care. So for example, if a patient who lives in Texas travels to California for abortion care, and the electronic health record system the California provider uses talks to the EHR system that the patient's family physician uses, the family physician in Texas can see that the patient accessed abortion care in California. This can be a problem for several reasons, including that a patient just doesn't want that information shared due to stigma or privacy concerns, all the way to a patient being threatened by a nurse or doctor that they'll report their abortion to the police or CPS. Though no state requires that a banned state provider report a patient's out-of-state abortion care, some healthcare providers are confused about whether or not they will be required to report in that circumstance. And this gets especially complicated where young people are concerned, as confidentiality protections for young people are slightly different than those for adults, and they vary state to state. The Department of Health and Human Services has proposed a new rule that attempts to at least partially correct for the privacy risk that interoperability poses for reproductive health care, but we don't expect that final rule to be out for a while yet. And in the meantime, I think it would be really helpful for providers to learn more about what exceptions exist to the interoperability rule, some of which may apply in cases where you're delivering abortion care or other sensitive health care to someone who lives in a banned state. But that is a whole other presentation. And I think that Dr. McElmore has some things that she wants to say about HIPAA.
I do, and I really appreciate you bringing this up. 2 points. And not just because I'm in Washington State, which was one of the first states to really adopt a more advanced understanding of patient privacy and legal protections under My Body, My Data. But for this audience, 2 pieces of information that are very important for you to know. Number one, HIPAA is over 25 years old, and it does not cover all digital healthcare communications. So your Apple Watch, your Fitbit, any community like consumer-driven health information is not covered under HIPAA. So when you see the stories in the news around information about abortion being turned over from social media companies or from consumer-driven products, just realize that HIPAA is a very specific provision to the sharing of healthcare information. And number two, I think it's really important that we have conversations with patients about what their direct desires and needs are in terms of what we document in their medical record. And this is not just specific to abortion care. We also see this again going back to the birth center, home birth, pregnancy, however pregnancies in side of things, that there are places where we do not want opportunities for criminalization or racial profiling, quite frankly, to occur in the official medical records of the people that we serve. So HIPAA is an old law, and not all health communications are covered under it, nor consumer-driven products of health. And we also want to engage the patients themselves around what should and should not be documented in that health record.
I'll just piggyback on that to, bring us back around to the understanding that it is impossible to distinguish clinically between someone who is coming in with complications from a self-managed abortion versus someone who's coming in with complications from a miscarriage. So we need to be especially careful around what we document in the chart around those kinds of situations, keeping in mind that our words can be used against the patient unless we're very careful about what we document.
And I would say that it's good for you all to have an understanding of when exactly the scenarios are where you have to turn over information and how much of it you can redact, right? So there are some resources that I can make sure that we share with you after the presentation. And then there's also, I think, just generally having a conversation within your hospital or your care setting about that is important, because sometimes the answer is, well, I don't know, well, I'm not sure, right? So this isn't something that folks necessarily think about. And honestly, like, it's not fair that you have to think about it. There's really an expectation put on a lot of healthcare providers, I think, to understand the law and be a lawyer at the same time that you're trying to provide healthcare. And it makes me upset because I don't want you to have to do that. And I don't think it's fair that the state sort of deputizes you in that way and sometimes makes you, have to be aware of all these things in order to provide the care that you need to provide. It just shouldn't have to be something you worry about. But it's I'll step off my soapbox. And I want to call back to something that Dr. McLemore said about, how there have been cases in the news where folks are criminalized based on text or social media, right? So I want to point it out. I want to dive deeper because this often is something that folks are really concerned about in terms of their digital information, right, getting shared. And I think that the one thing that I want to say here is that the biggest risk, I don't know, is that digital information is sort of shared, on accident because someone is sitting in a particular location, et cetera. The biggest risk is other people. The reason that folks have their text shared, the reason that folks have their social media shared is because someone screenshotted it and shared it with the police, right? And this is really, it's a hard pill to swallow when we're thinking about abortion stigma, because what all of we know about stigma tells us is that being, really talking more about abortion and sharing abortion stories is really important to busting stigma. And in these cases, especially where someone is self-managing an abortion, the more people that people tell about that experience, the more their risk goes up for being criminalized. And that is it's a sad state of affairs, but it's something that I think is important for you all to know, because if you become a safe person that your patient wants to talk to about considering self-managed abortion, it's important that you are able to direct your patient to resources like our helpline that will be clear with them about what these risks look like and why, keeping the number of folks who understand or who know about the self-managed abortion to a minimum can be protective, even if it just overall stinks as a scenario that we have to consider, right? I would love it if everyone could be as open as they want to be about these things, and some folks are, but those folks know the risks, and they are being open purposefully about those experiences because they want to bust stigma. So the Repro Legal Helpline I've mentioned, it's a helpline where folks can call, they can text, they can fill out a form, any of those things in order to get legal advice about self-managed abortion or legal information about self-managed abortion. The Repro Legal Defense Fund is actually a bail fund, and it exists in order to ensure that people who are criminalized for pregnancy decisions have access to bail. Getting people out of jail in the beginning of a criminalization process is really, really important, because it means that they can have fuller and more unfettered access to legal counsel. It means that they can be with their families, make arrangements for childcare if they need to, right? If they know that they're going to be incarcerated. There's just a whole slew of reasons why it's really, really important to get people out of jail as soon as possible once they're criminalized. So that's a bail fund that exists. This is slightly related. I'd say more than slightly related. We also are involved with a bail fund that is for trans folks who have been criminalized for receiving gender affirming care. So we'll include that in the resources as well, but I want folks to know about that. There's also a resource called the Miscarriage and Abortion Hotline. It's a hotline that's staffed full-time by medical providers, and it is a place for patients to call if they have questions about miscarriage and abortion, the medical aspects, right? So people will call and say, is this too much bleeding? And the medical provider can really walk them through that and let them know when it's time, if it's time to go to the emergency room, or if it's normal, et cetera. Are their symptoms normal, right? I think going through a miscarriage or an abortion, if you never have before, can be a scary process. And so having this hotline where people can call that's anonymous, right? And they can get this anonymous care and advice from medical providers, I think is really important to know about. Abortionfinder.org, which is a website that's recommended by the Department of Health and Human Services. It is a website where folks can go on to find abortion providers. They can find practical support networks to help them with travel. They can find their local abortion fund to help them pay for care. And then the National Network of Abortion Funds is a more specific resource for funds to find your local fund in your state and to make sure that you can get funding for abortion care. I've already talked a lot about the Abortion Defense Network. And then If and How has a technical assistance form that I'll make sure to include in the resources that you can fill out if you want more information on mandatory reporting in your state. So I'm working right now on fact sheets for all 50 states, all about mandatory reporting in each state. And we're not done yet, but if we have your fact sheet, we'll send it to you. And if we don't, I will personally look up the laws and make sure that you get the information you need. And with that, I will stop talking.
All right, so having talked a bit about some of the legal issues around self-managed abortion and criminalization of pregnant people, we're going to start talking a little bit more specifically about ethics. And the ANA Code of Ethics for Nurses applies to all of us, whether we're advanced practice nurses, bedside nurses, LPNs, whatever our credential is. The ANA Code of Ethics is our go-to resource that applies to everyone, and that's available online. It includes kind of a large book that has all the interpretive statements as well. And I promise I'm not going to go through all of them because we do not have that kind of time, but I'm just going to touch on some of the key provisions that affect what we've been talking about here. And I hope that Dr. McLemore will jump in as desired as we kind of go through these. So the first provision is really about patient autonomy. It speaks to the rights of patients to self-determination, that autonomy piece we talked about way in the beginning, and to be cared for in accordance with their values. So in other words, we all have personal values as providers, and that's great. We all should have personal values. When we step into the role of a nurse, our professional values require that we treat our patients as they request to be treated and in accordance with their own value system, which might be very different from ours. So as we do as in shorthand in my gynecology course, we say it's not about us, it's about them. Patients have, quote, the right to determine what will be done with and to their own person. And a nurse must respect patient decisions, even when those decisions may conflict with the nurse's own values. So that's speaking very directly to pregnancy decisions, as well as many other decisions that patients might make. Now, Provision 1 does not require that we support or agree with patient decisions. It just requires us to establish a relationship of trust that sets aside biases and prejudice. And of course, I think we talked about how important it is to establish relationships of trust, especially when things get difficult. In terms of what gets recorded in the medical record, this is a place where, we can really think about how can we establish trust, or how might we be breaking trust.
And I just want to add on to Provision 1, and it's also directly related to Provision 3. And you can go to the next slide.
Okay.
When we conducted our study, Calculus Formation, really understanding how people develop their thinking, their engagement with ethically challenging care, using abortion as an exemplar, we have data that actually bore this out, that this notion that, and we want to be very clear on this webinar, we understand the nuance behind wanting to talk about and teach and educate our colleagues around abortion. Because one place that I think really needs to be highlighted under Provision 1 and Provision 3 is, in our qualitative research findings, we found that this is a very complicated issue for nurses. And in our quantitative surveys with the Association of Women's Health Obstetric and Neonatal Nursing, and even the nurses we surveyed in the state of California, this is very complicated because people have had their own pregnancy-related decisions to make. And there's no place in our educational trajectory for us to be able to distinguish our personal experiences and how we felt at the time of our own pregnancy decisions, and then being faced with supporting people in their own pregnancy decisions in real time. So the point I want to make here is that educational institutions, professional organizations, I think we have a unique opportunity to provide some opportunities such that when we're training nurses, and this is part of what this webinar is, that their first educational exposure isn't having to attempt to unpack their own values about this while being confronted with the patient's values and the decisions that they need to be able to make. That there needs to be other simulated spaces where those emotions, those feelings, those thoughts, our own knowledge base can be unpacked, that will allow us to be the trustworthy providers that patients are looking for us to be in those moments.
Thank you. That's really, really helpful, because I do feel like we just naturally, we bring ourselves into our care. And if we have anything that is just unexamined, unresolved, unconscious, that we haven't addressed, then that can come out in ways that we really don't intend when we're taking care of patients. So I just really appreciate that discussion. So Provision 3 establishes the duty of the nurse to protect and advocate for the rights, health, and safety of the patient, including the right to privacy and confidentiality. And this speaks very directly to what we've just been talking about around privacy and confidentiality, and when we need to report and when we need to not report and not share personal health information, private health information of our patients. It explicitly acknowledges the damage to the nurse-patient relationship that can result from a breach of confidentiality, and that this can result in a loss of patient trust, and it can jeopardize patient well-being. The duty to protect confidential information is limited. It is limited by law, such as when disclosure is legally mandated due to public health, safety, or health considerations. So, for example, that is why some STIs are reportable. But I think, the way to think about some of this disclosures is, if someone gives us a subpoena, then yes, we have to comply with the subpoena. But short of that, we should be really thoughtful about disclosure and avoid disclosing any personal or private or protected health information to anyone who does not have a direct need to know, because it can jeopardize our relationship with the patient, and it can jeopardize our patient's health and legal safety. Provision 4, and I'll just read it to you. The nurse has authority, accountability, and responsibility for nursing practice, makes decisions and takes action consistent with the obligation to provide optimal patient care. And this establishes that nurses are accountable for our own conduct, even though institutions may at times share responsibility. So as we just discussed, you might have an institution that is pushing you to conduct yourself in a particular way that might be a little bit more limiting than you think is in a patient's best interest. And in that case, you might want to consult some of these resources that have been provided so that you get another opinion about what you can do on your own, based on your own the provision for that makes you accountable for your own conduct. It is a tough one, as Lauren Polk just talked about. It kind of, we don't want to become attorneys or try to become attorneys, but we do have to acknowledge that our institutions may at times ask us or pressure us to do things that we feel are not ethical and in the patient's best interest. And in that case, we do need to advocate for the patient to provide optimal care to that patient.
In 2015, when the interpretive statements and our code of ethics were being reviewed, our good colleague, Dr. Amy Levi, and I went to the ANA's meeting to specifically argue for the language here in provision 4, because we wanted nurses to know that they would be protected, especially when making referrals. So regardless of how you feel about abortion, ensuring that people are safe and are referred for care is part of our role. And we wanted to make sure that people were protected and had that extensively called out in this particular provision. So when you see the interpretive statements under that, referring people is not active participation in care. And again, as Lauren just beautifully laid out, information is very different than advice.
Provision 5 obligates us to treat ourselves with the same care and respect we show to our patients, especially regarding our wholeness of character. This means that we are moral actors who have duties to our own conscience and not just to other people or to our patients. And ensuring that we live in accordance with our own convictions may sometimes mean refusing to participate in certain kinds of care, but it also may mean deciding to provide care when evidence supports it and our personal convictions tell us it's the right thing to do. If we do have conscientious objections to providing certain kinds of care, we have a duty to make that known in advance so that the patient's options and health are not compromised by our decisions. In fact, we need to let people know ahead of time in our setting and ensure that there are provisions in place to meet the patient's needs. So how might this look? Let's take options counseling as an example. Occasionally, I talk to nurses who are so personally opposed to abortion that they feel that they can't, in good conscience, discuss the option of abortion with their clients. And some of those nurses are my colleagues, students, and friends, and I want to be clear that it's very possible to feel this way and still be an excellent nurse midwife or nurse practitioner. In these situations, using what I call the artful referral works pretty well. So to do this, prior arrangements are made with another clinician in the setting so that when a client needs options counseling, the nurse who's uncomfortable providing it makes this kind of seamless referral. And to do this, let's say there's a positive pregnancy test. What you might say is, my colleague Sam really keeps very up to date on all the resources that are available in our area for someone who is facing a pregnancy decision. And I'd like to pull Sam in, if it's okay with you, just to make sure you're getting the most up-to-date information available. And that's a way to make this collaboration happen that does not let the patient know how you as a nurse may feel about it. It's really making sure that your own values stay out of the equation entirely. Now, Provision 5 does not allow us to opt out of care during an emergency, and it also doesn't allow us to break patient confidentiality. We must ensure that the patient is cared for in accordance with their own values. That's our duty no matter what. And additionally, Provision 5 states that nurses are expected to provide compassionate, respectful, and competent care, particularly to those whose situations are stigmatized. and when we encounter a conflict with our own personal beliefs. So this clearly creates an expectations that as nurses, we go the extra mile for people who are experiencing stigmatizing conditions like undesired pregnancy to ensure that they get the care that meets their needs and in keeping with their own value system, especially when we may not agree with how they plan to address the situation. Okay, moving on to Provision 8, and I'm going to wrap up with this one. Provision 8 explicates a duty of the nurse to advance health and human rights and reduce disparities. And we are to do that by collaborating with others to change unjust structures and processes that affect both individuals and communities. I hope we've made a case for you today that laws that restrict access to safe and legal reproductive and abortion care provided by clinicians are not going to have equitable consequences, but are going to advance health disparities instead. These laws contribute to legal and health jeopardy, particularly for people of color, up to and including serious morbidity and death. And Provision 8 suggests that we work together as nurses to try to reduce harm and improve equity. And we can do that through providing direct care and also through advocacy work and using our voices with lawmakers. All right, I'm going to go ahead and turn it over then
Awesome.
to Dr. McLemore. Thank you.
So, first of all, for those of you who hung in here with us, we are so deeply appreciative of your open-mindedness, your willingness to engage with this content, your hopefully, compassion and empathy to really try to start to think about, providing really great care in ethically challenging situations and circumstances. In that vein, I always like to try to model the behavior that I'm hoping that we as a profession and a discipline will bring forward. And every time I say this, at least in public or when I've said it in conferences, there's been this like audible gasp. So I feel I used to not talk about my own reproductive trajectory because I did not want to participate in perceived stigma. But I've started to hone some better language working with abortion storytellers to be able to start my presentations by saying this very important sentence. And that is, I have studied reproductive health rights and justice my entire career. I have published both scholarly and scientific work in abortion, in birth, around midwifery. I have published pieces for the public around abortion and birth and midwifery. I have never had to make a pregnancy decision in my life because I knew I never wanted to be a parent. And I'm really grateful that I haven't had to do so because I say this with all truth and honesty, despite the body of my work, I have no idea what I would decide. And I think that's a really important piece of information because people make all sorts of assumptions about pregnancy decisions or when people sit on a particular spectrum, both personally, and that somehow they can't distinguish that from their professional work. But I honestly can say to you, as an ex-evangelical person who really has helped 58 different families through pregnancy and childbirth in my entire career as a nurse, and who've helped hundreds of people, maybe even thousands, have abortions, I have no idea what my own personal pregnancy decision would be. And I want to live in a world where that's okay. This study that was led by Amy Allspaw, one of our midwifery colleagues who is currently faculty at the University of Tennessee in Knoxville, we had some quantitative data where we worked with the Association of Women's Health Obstetric and Neonatal Nurses. And these data, along with the qualitative data that I collected in my postdoc, they further affirm for me that this is a nuanced discussion. It's complicated. And for too long, we have been too lazy to accept polarized language that has been fed to us, either from anti-abortion people or people fighting so hard in the courts for pro-choice, that we haven't developed our own language, our own educational trajectories, our own pedagogies to actually understand how to have a very difficult, nuanced conversation grounded in clinical decision-making with patients who we should partner with to improve health outcomes, right? And I want to disrupt that laziness. So therefore, we decided based on the data that we had, not only did we publish the paper that we had in Women's Health Issue, the peer-reviewed survey of over 2,000 quantitative survey responses about nurses' perceived competence and their perceived confidence in their own attitudes and beliefs about abortion. We published a public-facing piece in Scientific American to really say we reject the either-or conversation, because then that leaves us no middle ground to talk about a very simple thing. Regardless of pregnancy decision-making, regardless of criminalization, how many people on this webinar believe that pregnant people, regardless of how their pregnancies end, deserve good care? I do, right? You can't have that discussion if we're being forced into polarized sides. So one incredible tool that we have as nurses is we adjudicate conflict all day, whether it's between, physicians and patients' desires, or incorrect or conflicting pharmaceutical order. We do this all the time. That's our job. And so we need to apply it to ethically challenging care when we can get past our emotional reaction to it. Next slide, please. One thing, and this was the paper, the scientific paper. So again, there is language in the public and that in the media that are being used. And we wanted to back that up by scientific data. In this study, we found that 66% of people are in what we call the mushy middle. They don't have strong feelings about abortion. They don't have strong feelings against abortion. They're in the middle. Under certain circumstances, they believe that they can participate and they can support it. In other circumstances, they can't. And guess what the number one reason that mediated that relationship? It was people's own pregnancy experiences. We had people who were adoptive parents who tried for years with infertility treatments to get pregnant and to have biological children of their own, and that didn't happen for them. Their aversion to abortion had nothing to do with how they felt about abortion. It was not the right choice for themselves, but they would be willing to support it for other people. And the questions historically that we've used as researchers, as scientists, as polling people, have not been granular enough to get at those distinctions. We bought into the laziness of polarization. Are you pro-life? Are you pro-choice? Not helpful. And it's not good enough, in my opinion, for the only discipline that I've ever worked in for the last 30 years. It's not good enough for nursing, which is why we developed a survey to ask the more nuanced questions. Because I can tell you, pregnancy is one of the most complicated things that any person will do in their lives. The people who are brave enough to propagate our species and trust another human to shepherd another human to this world, that's courage, right? And for those people who don't want to do that, that's courage. So we need different language. We need different tools to be thinking about abortion, self-managed abortion, medication abortion, induction abortion, right? We need different language, and the law is not good enough for nursing. And I think we have enough skills and tools to help curate a more nuanced conversation about this. Next slide, please. We have to talk about the real mental health implications of abortion restrictions for historically marginalized populations. But I would also argue, when we deny people wanted abortions, there is a mental health impact. I know that people talk about, or historically have tried to prove the mental health impacts of having an abortion, but there are actually mental health impacts of being denied abortions, right? If the number one reason, or one of the number one reasons why people want to end pregnancies because they can't afford to have a child, I have always argued, I'm worried that we are developing into a society where poor people can't parent, one of the most basic fundamental functions, right? That's a complicated conversation. And I want us to unleash our spidey senses as nurses to curate spaces for really nuanced and complicated conversations. We can't act like there are no negative sequelae to parenthood, and we can't act like all sequelae to abortions are negative. That's not true. We have to reject that. Some people reject parenthood. Some people regret parenthood. Let's not act like there is not a continuum among all of the pregnancy outcomes, because pregnancy is the condition, birth, miscarriage, infertility, abortion, these are outcomes of pregnancy. So when we think about the mental health sequela, can you imagine of trying to receive a wanted abortion, driving around from state to state, not getting it, and entering prenatal care late because you didn't get what you want? So then you have to also then deal with the stigma of entering prenatal care late. We can do better than all of this. And I need nurses to be leading in this space to push people to have a more complicated and a more nuanced discussion. Reject the false binary and reject the polarized sides, because our research and research of others have shown this is way more complicated than that. Next slide, please. So in summary, please know abortion can be complicated, and that's okay. However, it's not unique when we consider ethically challenging care. It's just not. Abortion exceptionalism is a lie that's been sold to us. There are way more complicated, way more nuanced things within healthcare and health services provision that we need to be able to address. Abortion was a convenient, lazy shortcut. Abortion terminology matters. There's a new paper that has just come out from the Society of Family Planning. We want to talk about medication abortion, procedural abortion, induction termination, self-managed abortion, right? We don't want to talk about elective or induced or all these other legal terms that are actually not clinically accurate, right? There are other clinical conditions that have been impacted by limited access to abortion. I mean, when you think about the routine pregnancy testing that we're doing of people of reproductive age, even to get things like, methotrexate and other drugs that manage lupus and other kinds of autoimmune conditions, drugs that people have been on forever, right? Now we're in a landscape where people are having difficulty receiving those drugs because they might be pregnant. That's a problem, right? And we need to address that problem, the might be pregnant problem. We as nurses have an ethical and a moral, I would argue, responsibility to provide care or to refer care for patients who are pregnant, regardless of how pregnancies end. And if there's nothing you've learned from this webinar, I know conscientious objection rolls off people's lips, but there is conscientious providers of abortion care, and that we both should be opposing criminalization of pregnant people, regardless of whatever those outcomes are. And please know that you have your state board of nursing, your state board of medicine, that we have the American Nurses Association. There are people who have clear guidelines for you outside of state legislature and hospital policy that will allow you to know what your ethical obligation is in multiple clinical scenarios to providing care for reproductive age and pregnant capable people. We are very grateful for your engagement, for your listening, and we really hope that this will spawn greater discussion and more curiosity and more questions, so that we don't just accept historically the false binary that existed under Roe. Dobbs affords us a very interesting opportunity to have some different and nuanced conversations that perhaps maybe historically we haven't had. And I hope that we all will have both the curiosity and the courage to be able to have those discussions. I think our next slide is about questions, comments, discussion. And I'm very grateful that you've been here with us. And I'm grateful to my co-presenters for being able to present this information to you in a meaningful way.
Thank you again to all of our fantastic presenters today. So many of our participants will be students. What are some key takeaways for future advanced practice providers?
Well, let me start by saying, first of all, thank you for joining our profession, especially in a time where we have been dismissed, disrespected, and not listened to. Being a nurse is the only work I've ever done for pay as an adult, and I've been a contiguously licensed registered nurse since 1993. So thank you for being courageous and curious enough to join our profession. What you can do is to seriously start to unpack your personal values and read what our professional values are, and try to determine if there is a gap between the two. Be honest with your clinical preceptors, be honest with your academic advisors that you may have some learning needs, that you may have some discomfort, that you may not want to engage at all. Know that there's a wider continuum than just yes, no. It's not a light switch, it's a dimmer. And you may need experiences or educational exposure to know where those places are. And that hopefully the first time you experience that won't be in front of a patient who needs your help.
Yeah, that's great. I'll just add that it's an incredible privilege to be with people, especially people who, there are some parts of practice that are joyful for everyone and that, will bring you joy as a clinician. And there's also other times when it is a deep privilege to be with someone who is not in their very best place, and to have the skills and the presence and the ability to be with them in those difficult places is also deeply meaningful for us, I think. And some of what Dr. McLemore has alluded to about kind of unpacking our own baggage and thinking things through ahead of time will help us stay very present with our patients in those moments, instead of having whatever script might otherwise be going on in our heads preventing us from doing that. So to take care of our own unpacking of all of our thoughts, feelings, personal experience, personal history, ahead of time will allow us to be present with our patients when they are in these situations a lot more effectively.
Just add, and I am not a nurse, I come from a family of nurses and I have so much love for you all. I think now is the time, while you are a student and you are energized about what you are doing, and you are thinking about what kind of nurse you want to be, to really get to know what resources might exist for your patients that might be struggling the most. You can't be expected to be anything and everything to your patients, right? You're their healthcare provider. You can't always provide them with everything that they need in that moment. So having a good handle and understanding on what resources exist outside yourself that your patients might need access to can be a really important thing, not only for your patients so that they have access to these resources, but also for you, so that you don't leave a patient encounter feeling helpless and feeling like you really wanted to do something for that patient and what they needed was out of your hands.
Thank you, everyone. Lauren Pock, you discussed if, when, how. How could any participants interested in becoming engaged in this important work do so?
Well, we're happy to have you, but I want to point out two of the organizations that Noelle is a part of that is very, very important to us, which is Nurses for Sexual and Reproductive Health. They are a really good window into a lot of what's going on in the field. And I think that they provide a lot of great resources, sometimes in partnership with us, for nurses especially. And so I think that's a great place to plug in. But If, When, How also has a lot of resources for medical professionals. I would encourage you, we are revamping our website right now. Maybe by the time this webinar comes out for you, it will be done. I'd encourage you to check out our website and look for resources that are intended directly for healthcare providers. And if you don't find what you need, I'd encourage you to reach out to us through our technical assistance forum and ask for what you need, because I really see it as my job as making it as easy as I can for you all to have the information that you need to provide high quality healthcare when it comes to these types of services that we're talking about today.
Excellent, thank you. Let's take a little bit deeper dive into reliable, safe resources for nurses, advanced practice providers, and our patients. Any other advice any of our wonderful panelists have?
You mean besides the resources that we've already provided for
Yeah.
individuals?
Did we miss anything? Is there anything that you thought?
Well, I do think for, people who are into professional organization, the American Public Health Association and the Sexual and Reproductive Health section, of which I am the past chair, has some great resources on its website, really thinking about abortion from a public health perspective. There are professional organizations within abortion care provision. The Abortion Care Network and the National Abortion Federation comes up as two membership organizations, mostly for clinicians and for nonprofit entities, but they do have individual memberships as well to provide people with fact-based and hopefully up-to-date evidence-based information. And then I really want people to disassociate or dissect themselves from, public opinion about abortion or groups' opinion about abortion. You get to have your own personal opinion about it. And then you want to know the ethics of the profession under which you're licensed, what your responsibilities are. I think for too long we've allowed for public opinion or, advocacy groups or other people to sort of dictate our perspectives on this, because it's content for some people that's very uncomfortable. But I would argue that we need to sort of engage with it to really know what our range is. And not just to consider ourselves anti-abortion, A, because it's difficult to think about, or B, because it's easier to adopt a polarized stance.
I think the more that you have these conversations, the easier it will be, right? So this is something that we know about difficult, challenging topics, is that the more we sort of exercise that muscle in talking about things that challenge us, the easier it gets to do that. And I mean, I think that no matter what your opinion is or what perspective you're coming from, you're not alone. It's pretty amazing being someone with an organization at a title and at an organization with a title that tells people what I do. I definitely have been at the dentist's office with like the clinician's hands in my mouth saying, I don't know if I would get an abortion myself, but I definitely think that everyone should have access to one when they need it. And me having to sort of mumble through the care that, she's not alone, and that I think a lot of people feel that way. So I think that that's important to remember too, is that you might, have these positions that you're afraid to talk about, and actually you might be one of very many people who feel that way.
Thank you again. For those healthcare professionals practicing in states with restrictive laws, what are some actions they could take to optimize patient care? We did talk about that somewhat in the presentation, but sort of want to put it out there if we have any key points again to bring us back to.
I just returned from Memphis, Tennessee, where Choices in Memphis, which is one of the few full scope, or it was prior to the fall of Roe, Black midwifery led clinical services, full spectrum, across the reproductive trajectory. And one of the things I said to them, we were at the first 8 in Memphis, which is a readiness for school infant mortality prevention organization. And I was talking with them about why it's so important that they start to engage around people in that sort of pre-pregnancy. Some people use the language of preconception. I don't like that language, but I'll use it here. Why it was important for them as a readiness for school infant mortality prevention organization to work with people, prior to pregnancy, to help with information, fact-based, evidence-based information sharing prior to becoming pregnant, but then also to be partnering with Choices in Memphis and Sister Reach and a lot of the community-based organizations that are doing direct service for the people who are most impacted and most harmed. Know the resources in your community and be able to be in relationship with them, right? It's very important that a lot of people, until folks enter formal medicalized care, people talk to clergy about their positive pregnancy tests. People go to crisis pregnancy centers or pregnancy health centers. They go to the internet. They go to family members, right? Try to get people to as much fact-based, evidence-based information as they can as they're trying to make these very nuanced and complicated decisions. Because guess what? People who come to pregnancy decisions don't come to them lightly either. It's nuanced, and they go back and forth as well. There was data from the Turner-Way study that suggested that, in addition to other research has shown, these aren't like light on, light off decisions for pregnant, capable people either, right? Sometimes it means staying involved with the partner in the pregnancy when they've been abusive. Sometimes it means staying involved in a situation where they could lose housing benefits. Sometimes, like, so it's not just nuance for us. And I want us to start treating patients with the respect that they deserve, because it's been a hard decision for them to make too. And then they had to make the second hard decision of coming to us and telling us about it. So let's add some nuance back into our practice. Let's add some compassion, some empathy, some humility. These are not easy decisions that pregnant, capable people make.
Yeah, I'll just add that many of us have never practiced in an environment where the legal standard of care or what our professional ethics suggest is the right thing to do was legally prohibited. We're in a new, it's really a new landscape for people who are in these banned states. And, you know, there is the risk of moral injury to people who are essentially forced by the state to practice in ways that go against their understanding of what appropriate and safe care means in these different situations. So I would say it's important to get support if you're in this situation. It's got to be incredibly difficult and draining to be in these kinds of positions, or to be concerned about being placed in these kinds of ethical dilemmas. And you'll need backup, you'll need colleagues, you'll need support, and you'll need safe places to talk about how you can push to make things better. How, again, our provision 8 that talks about collaborating to address unjust systems. I think collaboration is sort of the survival piece of that. So that we need to do it in community, we need to do it with others. So I think I'll stop there.
Dr. McLemore, could you kindly discuss pre-conception versus pre-pregnancy? We know language is so important today, and imagine that audiences will be interested.
So several groups, including Christine Dellendorf's group at UCSF, the program in patient-centered care and contraception, and some reproductive justice organizations have come together to really question this notion of the language of preconception, continuing to contribute to stigma of pregnant capable people or uterus having people that our only function or only value in society is as vessels for other humans, right? So people have tried to use language that's more specific around, across the sexual and reproductive health continuum, or, even pre-pregnancy assumes that pregnancy is desired. So wanting to use better language or more scientifically precise language to describe the time period when people are not pregnant, but have capacity for pregnancy. So this idea that we can be working in partnership with pregnant capable people. I mean, we still are using trial and error to understand how folks come to their sexual orientation, what contraceptive methods are best. Well, for some people, that's also true of pregnancy, right? But I would argue that we have better methods than trial and error. And so we should have better language to talk about the period when pregnant capable people are not pregnant, to partner with them to ascertain information about what their pregnancy desires or family goals are, and to get them the things that they need in order to be able to support said goals.
Thank you again to our esteemed presenters for sharing their expertise with us today. Also, we appreciate those of you leaning into expanding your own knowledge base as healthcare providers by participating in this session. If you've registered for this session for Midwifery Week, shortly you will receive an email with instructions on how to access the post-test and survey to receive continuing education credit. The recording will be added to the campus course in the next couple of days. If you're viewing this session after Midwifery Week and did not register ahead of time, you can find instructions on how to access the post-test by visiting the website on the screen.